Bueno, pues vamos a... Espera. Bueno, sí, tiene ahí otro. Vamos a seguir con la última sesión y se van a explorar un poco... es un poco putpurri lo que nos queda. Afortunadamente van a ser solamente 4 presentaciones, así que os rogaría que nos ciñéramos al tiempo, a ver si tenemos algunos minutos para discusión. Entonces le vamos a pedir al Dr. Walz que nos hable de la anatomía quirúrgica de la próstata para control del cáncer. Cómo preservar continencia y erección.
Thank you very much for the introduction. Again, thank you very much for the invitation to be here in Bilbao. You might be surprised after all this talking about focal therapy that there is still something called radical prostatectomy, which is still an option to treat prostate cancer. And actually, I like to start my talks about the anatomy of prostate cancer with this slide here. This is a sketch from Leonardo da Vinci, the famous Italian genius living in the 15th century. And actually, if you look in detail here, you will recognize that he was not aware of an organ called prostate. Here on this sketch of the sexual intercourse, you don't see anything below the prostate. And I call it sort of ironic that Intuitive used the name of Leonardo da Vinci to call his robotic surgery system Da Vinci, which is used today so many times to treat prostate cancer. And maybe in view of this fact, they might have chosen another name, but probably this is too late to do so. Today, we know a lot more about the anatomy of the prostate, and we know that the anatomy is very close in contact and does influence the goals of radical prostatectomy, which are cancer control, urinary continence, and erectile function, and they are all very close interconnected, and achieving the 3 goals is also called sometimes the trifecta. First, I would like to talk about the erectile nerves, which are, of course, important to preserve the erectile function. And it is important to know that the erectile nerves are parasympathetic fibers coming from the anatomia of S2 to S4. They further go then on to the pelvic plexus or the hypogastric plexus, which is found lateral to the bladder and to the rectum. You can see that here. And the lower parts of the pelvic plexus is then giving rise to the erectile nerves, which branch off very close to the seminal vesicles. And this is an important slide here. You see that indeed the nerves are very close to the lateral aspect of the seminal vesicles as well as very close to the tips. And this is here a schematic scheme. You really can see here that these nerves are very close. And you can do the best job ever at this side lateral part of the prostate, preserve the nerves there. If you mix up here in this area, then the entire nerve sparing lateral to the prostate did not serve anything. So this is one of the most important parts where you can do injury to the nerves, and this is another section where you can see how close they go next to the tips in the lateral part of the seminal vesicles. Then further on at the lower part, they run next to the prostate to the corpora cavernosa. And in this area, when we rely to the description of Walsh and Dunker, the nerves were considered to be only at the 5 and 7 o'clock position. Today we know that this is not really true. We know that 1/3 of all nerves found lateral to the prostate are also found at the anterior part of the prostate. 2/3 are found at the classical part, at the 5 and 6 o'clock position, and very few nerves are found at the purely posterior part of the 6 o'clock position, suggesting that this is a good area to enter into your nerve-sparing procedure. Do these anterior nerves really help to improve the erectile function? There's a lot of controversy going on about that, but there's one study, and there are many studies out there proving that this high anterior release does really help something. So you preserve these anterior nerves by releasing the nerves up here, you will improve the erectile function of your patients. You don't do this high anterior release, well, 50% of patients will recover erectile function, and if you do a high anterior release, you will have a 70% probability that these patients recover erectile function, so an increase by 15 to 20%, which is substantial. Is this really due to the fact that you preserve these nerves, or is it a difference in the dissection, or do you have an easier plane or easier entry into the nerve sparing? We don't know, but already the fact that you try to preserve these anterior nerves are improving the outcome, or is improving the outcome. It is important to know that the nerves are also very much in contact with the denovious fascia, which is the fascia between the rectum and the prostate. And actually, at the lateral aspect where the nerves are found, the denovious fascia is becoming a multi-layer tissue surrounding the nerves in a triangular fashion. And then further on, when it gets further down to the apex, it is important to see that here the nerves are close to the apex as well as close to the urethra, and this is another spot where they can be easily injured, so you need to be careful at that area as well. When we talk about nerve sparing, we really need to take advantage and really need to have a close look to the periprostatic fascias, to the anatomy next to the prostate. And we did a recent review on these aspects, and we used a terminology that helps us to define the different structures you might encounter. We had first, of course, the outer boundaries of the prostate, where actually there is no true capsule. We only have a pseudocapsule. This is dense fibrotic tissue. And on this pseudocapsule, you can find a layer, a fascia that is called the prophetic fascia. It is not always found in all patients, but in some patients you can encounter this fascia. Then, next to the outer part, you have what they call the areolar tissue, which consists of fatty tissue, nerve tissue, as well as vascular structures, the veins and the nerves. And then you can find here at the upper part the endopelvic fascia with its visceral part and parietal part, and then you have the fascia of the levator ani. And all this entire structure from the pseudocapsule of the prostate to the levator ani is called the periprostatic fascia. This structure unfortunately underlies a lot of anatomical variations, and this is one of the most important studies that is published addressing this question. Kiyoshima published in 2004 and actually had a look how the variability is regarding the nerves, and he found 50% of patients where the nerves are condensed at the classical position of the 5 and 7 o'clock position. And the other 50% of patients had an anatomy where the nerves are here on the lateral side of the prostate in a sprayed-like fashion distributed over the entire lateral, posterior, and anterior aspect. And this is another slide that shows you how the anatomy can be different from one patient to another. You have here on the left-hand side probably anatomy that provides you with an easy nerve sparing. You have a clear boundary of the prostate, and you can easily imagine how you can do the nerve sparing here. However, if you have a patient like this one here, where you have sort of like a fusion of the different planes around the prostate, then the nerve sparing here is definitely more difficult to do than in this patient here, and you have all the different variabilities in between. And to make things still a little bit more complicated, you do not only have an inter-individual variation, but also an intra-individual variation. This is the same patient, but if you compare the left and the right-hand side, you see here that there is actually no areolar tissue. The visceral part of the endopelvic fascia is fused with the outer boundaries of the prostate, whereas here you have the classical aspect of the periprostatic tissue. This is not an excuse for poor results, functional results after radical prostatectomy, but it explains why we're not yet at a 100% erectile function after surgery, because the anatomy has such a great impact on our results. The periprostatic fascia is the area where we do the nerve-sparing procedure, and we have different dissection planes we can use now in order to do our nerve sparing. Nerve sparing today is no more a yes or no procedure. We have today the possibility to increase the security margin on the prostate in order to stay at distance of extraprostatic extension. And in the review we did, and this is probably the most frequently used different dissection planes we can use. The first one is the intrafacial dissection, where you stay inside of the prostatic fascia, therefore in between the prostatic fascia and the prostate capsule. Inside, that is why it's called intra. And then the interfacial dissection, where you remain between the prostatic fascia and the fascia of the levator ani. And this is a dissection where you have a larger security margin on the prostate, but where you will resect also some nerves, because you will resect those nerves that are very close to the prostate. And then you have the extraprostatic dissection, where the extrafacial dissection, where you remain outside of the levator ani fascia as well as behind the noviae fascia, and this is a complete resection of the neurovascular bundle. There are other terminologies out there, like this, the full, partial, and minimal dissection, which is basically the same, very close to the prostate, an intermediate dissection and a large dissection. And then we have the definition from Tivari, who is using anatomical landmarks to define the degree of nerve sparing. And Tivari actually uses the veins. And if you have a perfect nerve sparing, which is a grade 1 nerve sparing, you remain beneath the veins, therefore between the veins and the outer boundaries of the prostate. A grade 2 dissection is on the veins, a grade 3 dissection is a little bit at distance of the veins, and the grade 4 dissection is what we call again the extrafacial dissection, a wide dissection of the neurovascular bundle. Patel also used landmarks to define his degree of nerve sparing, but he used the arteries to define the degree. And here, the scale is the other way around. The best nerve sparing is a grade 5 dissection, and the worst nerve sparing, or the widest dissection you can do, is a grade 1 nerve sparing. And a grade 5 dissection is on the outer boundaries of the prostate, beneath the arteries. If you do a dissection at the level of the arteries, then you have a small security margin on the prostate. And if you remain at the level of the prostate, you have a grade 3 dissection. A grade 4 dissection leaves a tissue layer on the arteries, and then the grade 1 dissection is again the wide dissection, the extrafacial dissection. So you can see, according to the risk of extraprostatic extension, you can individualize the dissection, and you can choose whatever dissection plane seems appropriate for you in order to achieve good oncological results, but also allow to the patient to remain, to keep an erectile function, because you conserve or spare the nerves. The second point I need to address is, of course, the urethral sphincter, in order to preserve the urinary continence. And the urethral sphincter is in very close contact to the pelvic floor. Here actually it is the anterior part of the levator ani that matters, and the anterior part is also called the puboperinalis muscle, which inserts, which has its origin at the level of the pubic bone and inserts at the central perineal tendon. And you will see later on how that does in fact affect the urinary function. The true urinary continence is assured by the urinary sphincters, and we have two of them. You have the bladder sphincter and you have the urethral sphincter. The bladder sphincter is at the level of the bladder neck, and it consists of smooth muscles, and it underlies an autonomic control. It is responsible for the long-term continence as well as for the bladder neck closure during ejaculation. And this is a schematic sketch that shows you the location of this muscle. And actually, it really enters into the prostate, and this is probably where you would do your bladder neck sparing if that is something you do during your surgery. But this bladder sphincter will be resected partly with a prostate if you do a radical prostatectomy, so the urinary continence will be assured by the urinary sphincter, which also assures the long-term continence, but consists of two different muscle types, the striated muscle and the smooth muscle. The urethral sphincter is located beneath the pubic bone, below the apex of the prostate, and dorsal to the dorsal vascular complex. And this is of importance because if you look at this picture here, you see that the anterior part of the sphincter is overlapped by the posterior parts of the dorsal vascular complex. And this is important if ever you consider to do one single stitch to control the bleeding from the dorsal vascular complex. You might take parts of the sphincter into your stitch, and with this you would render these parts of the sphincter non-functional, and the patient has a great risk of having urinary incontinence afterwards. So a selective ligation of this area is very important if you want to preserve urinary function afterwards. The urethral sphincter itself, the striated part, has a horseshoe shape or omega shape, a circular structure therefore, and it has a dorsal fibrous part where actually the muscles are inserting. And this is important because you will see afterwards how that works together with the puboperinalis muscle. Actually, if you do a contraction of the puboperinalis muscle, this will tear the entire structure to the pubic bone. If you do a contraction of the striated part of the urinary sphincter, you will have a contraction towards the rectum. And this ends up being a double sling mechanism, which allows to close the urethra to have a fast stop mechanism, and this is a mechanism that is done if you have a sudden increase in abdominal pressure, such as what happens if you cough or if you sneeze. So this part is very important to preserve during surgery in order to assure this continence mechanism. And this is here a dynamic MR that shows you indeed this contraction of the muscle, how that is really advanced to the pubic bone by the puboperinalis. The second part, and this is a part that is really responsible for the long-term continence, is the smooth muscle part. And here you have a circular part, which is indeed responsible for this function. And we have also a longitudinal part here, but we do not really know what this or its function is. Probably it is associated to the ejaculatory function, which is also taking place in this part of the body. Very important for the smooth muscle part is the anatomical shape of the apex. You can see here that you have wide variabilities of the apical shape. You can have here some sort of an overlap anterior as well as lateral over the urinary sphincter. You can have a circumferential overlap over the urinary sphincter. You can have here a lateral overlap, purely lateral overlap, an asymmetric overlap, or a posterior notch. Everything is possible. And you can easily understand if you would just consider this to be the limits of the prostate and you would just cut here vertically, you would sacrifice a good part of the urinary sphincter, and this patient would have a high likelihood to be incontinent after the surgery. So you really have an interest to fine-tune, to individualize your dissection at the apex, to preserve the entire sphincter length by dissecting into the prostate here, under control of view, of course, and really individualize the entire dissection, taking into consideration the individual anatomy of the apex, and this will help you to preserve every millimeter of urinary sphincter, and with this you will increase the probability that the patient remains continent after surgery. Last part is the innervation of the urinary sphincter. Actually, you have two ways to innervate the sphincter. One part is running with the neurovascular bundle, and another part is running with the pudendal nerve. There's a crossing over from the pudendal nerve to the urinary sphincter, and this explains why, if we do a nerve-sparing procedure, patients will have a better urinary function afterwards. But if we do not do a nerve-sparing procedure, this cross here will allow to have urinary control afterwards, but often it takes a longer time to recover. It is also important to know that the nerves enter into the muscle at the lateral part, 3 to 5 o'clock position or 7 to 9 o'clock position, and this 3 to 30 millimeters caudal of the apex. So you definitely should avoid a lateral dissection of the urethra. You should not have a long urethra visible during surgery, because with this you would risk to denervate the sphincter muscle and it would not be functional anymore. And I thank you very much for your attention. I'm happy to answer questions.
Congratulations for your presentation. ¿Alguna pregunta en la sala? Pepe?
Thank you for your talk, quite interesting, but I'd like to have your opinion on the role of the extended lymphadenectomy we do nowadays on the functional results, both in sexual and continence rates, because we all have the feeling that these big lymphadenectomies they do harm the continence rate or the recovery of it. Do you think so?
Regarding urinary continence or regarding erectile function?
Regarding more incontinence than because most of these people we do not go for bundle preservation because they are high risk. Bilateral, most of them. So, but the incontinence rate, I've been surprised because they get worse results.
I think it is linked to the fact that they do not have nerve sparing. That's the reason why they have probably a poorer urinary function outcome. It's not associated to the lymph node dissection, but to the fact that you do less nerve sparing in these patients because they are at high risk. I think that would be the influence. Regarding erectile function, I completely agree that the lymph node dissection does put the nerves at risk. If you do an extended lymph node dissection, you especially go into the presacral areas, you're at great risk to resect a part of the pelvic plexus or the hypoglossal plexus, and with this probably you will increase the likelihood of having patients that have erectile function afterwards. Of course, some of the nerves that are responsible for urinary function might also found in this area, and that might be a reason also why they have a poorer urinary continence outcome afterwards. But I would consider the lymph node dissection being more something that puts the erectile function at risk than something that puts the urinary function at risk, based on the anatomy.
If there is no other question, yes, I would like to. I've been very, very impressed for the presentation. I think probably it's the best I've ever listened on anatomy, and this is a topic I really like it. And I saw the review, and I saw one reference to Myers from Mayo Clinic, and on that, the only thing I think it could be added is kind of a historical perspective of that. And I will tell you why. This is a conflict of interest, because probably the first guy in talking about all this anatomical relation was Salvador Gil Vernet.
I actually have, I did not put that here in, unfortunately. There's a German surgeon, I think, or he was an anatomist, I don't know, who lived in the 1850s or something, called Müller. He described already precisely the anatomy of the erectile nerves, lateral to the prostate, and that was like, yeah, you see, many, many years ago, before anybody was talking about nerve-sparing radical prostatectomy. And often Walz and Donker are giving the credit that they found the anatomy of the nerves, but actually what they described is the nerve-sparing radical prostatectomy, but they are far from being the first to describe and to identify the nerves responsible for erectile function.
Yes.
If that was Müller or somebody else who described it first,
I don't know the work from Müller, and that will be kind of 1 century before, as you say. But the work by Salvador Gil Vernet was in the mid-40s. In the mid-40s, and he's very, 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 very much consistent with everything you are explaining us. So I follow with a lot of attention, because, and you had the good thing from you is you took the anatomy and you take it to the clinical practice. So just to congratulate you for that presentation. Thank you.
Thank you.